Hello, everyone. Thank you for having me at this wonderful event. My name is André Machado. I am the chairman of the Neurological Institute at Cleveland Clinic and a professor of neurosurgery. My area of focus is in surgery for Parkinson's disease, and I do that as part of the wonderful team of the Center for Movement Disorders here at Cleveland Clinic, the Center for Neurological Restoration. It's good to be with you today. I will be talking about surgery for Parkinson's disease, what it's for, what are the possibilities, when do we consider it, and how is our approach here at Cleveland Clinic towards treating patients that require surgery to manage their symptoms. One of the resources that I would like to offer today include this article, which is very appropriately named, Deep Brain Stimulation, What Can Patients Expect from It? The link is there. It's a link to the Cleveland Clinic Journal of Medicine. You can sign up for the content for free. You have to put in your email and create a password. There is no cost. And then you will be able to download for free this article, as well as any other article from the journal. This was really written for general clinicians, for general practitioners, internal medicine, and family docs. But it's written in a way that I think serves patients and families as well. The language was written to be very accessible. And I think it's a resource that you can have, download, and discuss with your doctor and loved ones as well. This is the outline of what I will be discussing with you in the next 20 minutes or so. We'll be talking about why surgery for Parkinson's disease, if and when surgery can be appropriate for you and for your loved one, and if so, how would we do the surgery? What are the surgical options for patients and families to consider? Who are appropriate candidates? In other words, who are the patients that can potentially benefit from having surgery for Parkinson's disease? Well, surgery addresses the so-called cardinal motor manifestations of Parkinson's disease. And they include tremor, rigidity, slowness, and the freezing of gait. The quick way to remember it is that surgery tends to work well for the movement symptoms involving the arms and the legs. It's very effective for tremor, and also very effective for slowness, stiffness, and for that freezing in initiating gait that so many patients with Parkinson's disease have difficulties with. Surgery is typically considered when patients have already attempted to manage their symptoms with medications, and it's getting difficult to have good quality of life with medications alone. We'll be talking about quality of life in a second. We consider patients to be good candidates when their medical treatment is quote unquote maxed out. The neurologists are having a hard time maintaining good symptom control during the day because there is a big difference between when the patient is on the effects of the medication versus off the effects of the medication. And the time, the duration of the effects of the medication is becoming shorter in such a way that you spend more time struggling with the symptoms than enjoying the benefits of the medication in a day. Also, when the drugs have been increased to the point that they are causing side effects and dyskinesia, those quick movements side to side that are typical of the peak of the use of the dose after the pills have been taken, the dyskinesias are often a reason why we recommend surgery, because surgery can be a very effective way of managing dyskinesias. We do a test called the levodopa or L-dopa response test, meaning we ask patients to come to our clinic off their medications. We videotape the symptoms of medications, and then we give our patients a dose of L-dopa, and we see how they do. If the patients improve substantially with a single dose, but are having difficulties maintaining good quality of life throughout the day as the pills wear off and you need to take pills again, those patients are considered to be good candidates. If the patient has no response at all from L-dopa, that is a concern, and it will be something to be discussed. My patients often ask me about age. Is age a contraindication? Well, age is only relative. We are much more interested in your health than your chronological age. An older patient that is overall well, doesn't have lots of medical problems, is an excellent candidate for surgery. Likewise, an older patient or even a younger patient that has many serious medical problems can be at higher risk and may not be as good a candidate for surgery. So age is only a relative concern. There is no absolute number that is a cap for when we no longer recommend surgery. We have concerns about dementia. Surgery is not recommended for patients who have dementia or serious decline of cognitive function, and surgery does not help the cognitive decline that sometimes is associated with Parkinson's disease. Everyone gets an MRI, and we want to make sure there are no major problems or lesions found in the brain. And good candidates have realistic expectations about surgery. I will go over those in a moment. But surgery is not a cure. In fact, when we say that we are doing the surgery for Parkinson's disease, that's a little bit wrong, because the reality is that we're doing the surgery for the symptoms of Parkinson's disease. It's really to manage symptoms. It doesn't cure the disease itself, and it does not prevent the disease from progressing in the future. It manages the symptoms for quality of life. And we need our patients to be committed, as we are, to the long-term follow-up. We cannot do the surgery, we cannot put a medical device in the brain if we do not have a reasonable belief that the patient will remain with us and will follow up with us so that we can do our jobs and be able to treat you and your loved one long-term. What's the gist of this? Let's recap what I just said. In other words, why do we do the surgery? We do the surgery to improve symptoms like tremor, slowness, and stiffness. And the chances that surgery will achieve that are high. We can never guarantee, but the odds from the last hundreds of patients that have undergone this surgery here at Cleveland Clinic indicate that the odds that we'll be able to ameliorate tremor, stiffness, slowness are quite high. The chances that surgery will cure Parkinson's disease are zero. The chance that surgery will prevent Parkinson's disease from progressing again, also zero. So why? Because the surgery can make the quality of life better and significantly better for quite a long time. This is the reason why we consider and often discuss and recommend surgery as a way to help manage the symptoms and the decline of quality of life that often happens when Parkinson's disease becomes advanced. What about the when? If and when the medications alone cannot provide the relief that you're looking for, or provide a relief at the expense of side effects that are not easily tolerated, like, for example, dyskinesias. When quality of life is declining, what does that mean? It means you cannot do the things you want to do. You're losing your independence. You're losing the ability to do the everyday activities, as well as losing the ability to do the things you enjoy, or inability to do your work. The symptoms are predominantly affecting the arms and the legs. Remember, tremor, rigidity, slowness, difficulty with gait. The surgery is less likely to help other symptoms, like, for example, swallowing or difficulties with urination. And the surgery does not help with dementia and is not indicated for patients with severe cognitive problems. How do I know if I am a good candidate for surgery? It's one thing to understand those criteria, but they sound generic. How do they apply to the individual person? How do they apply to me or to my loved one? Let us do an evaluation. Let us see you. And the evaluation is comprehensive, and it's comprehensive for a reason. We want to paint a picture of each of our patients individually. And that is by having an evaluation that includes a movement disorder neurologist, a movement disorder specialist, a neurosurgeon or a member of the neurosurgery team, a psychologist or a neuropsychologist to evaluate the cognitive function, as well as any behavioral problems like anxiety and depression that often come with Parkinson's disease. Videotaping the symptoms of Parkinson's disease off medication and then on medication, as well as imaging. Typically, we prefer an MRI, but if there is a contraindication for an MRI, like, for example, if you have a heart pacemaker, we will use another modality like a CAT scan. Then all of us bring our information to the most important activity that we do in our Center for Neurological Restoration, which is the Patient Management Conference. When we all come together Tuesday night to talk about the patients that we evaluated the week prior, we all bring our information, and together we put together the puzzle and we make a recommendation. The recommendation can be that you or your loved one, that you are a candidate for the surgery, or the recommendation can be, let's try something else. If the recommendation is for surgery, that is only a part of the discussion. The greater discussion is, what do you want to do? It's one thing to know that you can have the surgery. It is a greater question whether you should have the surgery. And that's something that you decide with us based on your values, your preferences, based on understanding what the surgery can do, as well as the risks or possible downsides of the surgery. And we'll discuss that in a moment. If the surgery is recommended, what surgery do we do? How do we do this? Well, there are a couple of options. One option is deep brain stimulation. Another option is something newer called high-focused ultrasound. Deep brain stimulation is surgery. It involves placing a medical device in the brain. High-focused ultrasound is done in an MRI suite. It doesn't involve a skin cut or making a burr to do the surgery. It's all non-invasive, and it's done by damaging a part of the brain. There are pros and cons to each of this. Deep brain stimulation for Parkinson's disease is much more common than high-focused ultrasound. And the reason is that it's reversible. We'll talk about that in a second. We can do it with you partially awake, meaning wake you up for a part of the surgery to do the mapping of the brain, and we can also do it under general anesthesia. The reason that we have all these options is because at Cleveland Clinic, we want to tailor the surgery for you. And we deliberately created several options to be able to prescribe the one that best fits each individual patient. Deep brain stimulation has been around for quite a long time. Deep brain stimulation is now FDA approved for, I think, almost 20 years. There are several areas in the brain that are considered when we do the surgery for patients with Parkinson's disease, including the subthalamic nucleus, the globus pallidus, pars interna, as well as the ventrointermedius area called VIM. And just like picking the general way of doing the surgery, we recommend one of these specific sites based on your specific characteristics that we discussed during our patient management conference. Most of our patients today have the surgery awake because it allows us to not only map the brain, but once the wire is inserted, and you see that happening on the left side of the screen here, we can test the movement and test how the stimulation is working before we finish the surgery to see if there is benefit for the tremors, the slowness, the stiffness. And that's a very strong predictor of how this is going to work in the long term. And we can also evaluate if there are any side effects. The other way of doing the surgery, if the patient is not a good candidate for having the surgery awake, or if the patient does not feel that he or she can have the surgery awake, is to do it under general anesthesia. And we have several ways of doing this, including obtaining imaging in the regular operating room with something that is similar to a CAT scan, or a special suite at the Cleveland Clinic where there is an MRI that comes inside the room to obtain images as we're placing the probe in the brain. In the right bottom, you see me verifying where the probe was inserted. And this is how we know that we have accomplished our objective. When we do the surgery awake, we rely on the symptoms and the improvement on the symptoms to see that we are accomplishing the objective of the surgery, that things are getting better. When we do the surgery under general anesthesia, we use the imaging to see if the probe is getting placed in a location that we think will work well in the long term. Either way, regardless if you do the surgery one way or the other way, the objective of the surgery is to place the probe in a location that is believed to result in good improvements of the symptoms long term, while avoiding the structures right next to the area of the brain that we are targeting that can be a cause of side effect. And measuring this and learning how to do this better is something that we extensively research together in our team here at the Cleveland Clinic. This is one of the examples of our scientific studies on how to improve the placement of these probes. What improvements have there been in the last 20 years? If we have been doing this for 20 years, is it all the same? Have we been able to make some improvements? Yes. I showed you some examples where now we have different techniques for doing the surgery, and we're able to prescribe to you the one that we think fits you best, or the one that you think fits you best, including having it awake so we can check on the symptoms, having it asleep, utilizing an imaging technology to verify how the probes are being placed, how the wires or electrodes are being placed. And there have also been developments in the technology. The electrodes themselves are becoming quite smarter. This is an example from one of the 3 companies that make deep brain stimulation devices, showing that they have been able to make the wires, the electrodes, smaller and fragmented, allowing us to push the stimulation one way or the other way to maximize how much improvements we can offer to the symptoms while minimizing the spread of the current, the spread of the treatment to the areas adjacent to the areas that we want to treat, because those areas can cause side effects. What about the other type of surgery, so-called high-intensity focused ultrasound? This is a surgery that's really done not in an operating room. You see here Dr. Sean Nagel, my partner in neurosurgery, treating one of our patients inside an MRI that has been adapted with a special device, the high-focused ultrasound device, that is built to damage a small part of the brain in an area of the brain called the thalamus that is associated with tremors. And you see here the before and after from early in the morning to a couple of hours later when the treatment was complete, as the tremor tested with this spiral has significantly improved and is expected to continue to do well for a very long time. And again, our patient now in the recovery suite, sitting down, getting ready to have the halo removed from the head, showing how the tremors improved comparing before and after. How do we pick? How do we pick which one is right, which one is best for each patient? Well, the high intensity focused ultrasound is really only good for tremor. It does not help the other symptoms of Parkinson's disease, like tremor, like stiffness or like slowness. The high focus ultrasound is only good for the tremor. The deep brain stimulation works for all of them. Works for the tremor, for the slowness, the stiffness, as well as for freezing of gait. And it also allows for better reduction of the medications, and it is a better treatment for the side effects of the medications, such as the dyskinesia. The majority of patients with Parkinson's disease are usually recommended for deep brain stimulation when they need surgery. For some patients whose only symptom or whose predominant symptom is tremor, we can recommend the high-intensity focused ultrasound. What other indications are there for the high-intensity focused ultrasound? Well, if the patient is unfit for surgery, has high risk for surgery, for example, major heart disease or severe lung problems, making surgery riskier, we often recommend the high-intensity focused ultrasound, because even though it can only treat the tremors, sometimes relieving the tremors alone can be a major opportunity for improving quality of life. The high-focused ultrasound treats only one side. With deep brain stimulation, it's possible to treat both sides. How do we pick the side? Well, we ask the patient which side they would prefer treated. Most patients prefer the dominant hand, meaning if they are right-handed, most patients will prefer the right hand to be treated. High-focused ultrasound is permanent. It cannot be reversed or adjusted over time. Deep brain stimulation can be reversed and can be adjusted over time. And high-focused ultrasound is a little newer. We have been doing it for a couple of years, whereas deep brain stimulation has a very long established track record. What are the risks of these surgeries? Both deep brain stimulation and high-focus ultrasound. I think the most concerning risk when we do surgery in the brain is the risk of a bleeding in the brain or a stroke. Strokes can be small, and sometimes the patient can recover over time. Strokes can also be large, devastating, and impossible to recover from. Infection. And then you have the overall risks of any surgery, which include the risk for life, the risk of death during surgery or from a complication of the surgery or a complication of undergoing general anesthesia or sedation. There is always a risk that we'll need to go back and redo the surgery. And this can be because we did not accomplish what we were attempting to accomplish in the first place. pain in the site of surgery is a risk and typically resolves over time, but yet a risk and a complication of surgery, as well as problems with balance and walking. And this is something that can happen with both types of surgery, but is more common and more frequent after having the treatment with the high focused intensity, with the high intensity focused ultrasound. It likely improves over time and usually improves over time, but it's a risk to consider. These are some of the risks of the surgery to be discussed today. When you come for your evaluation, we will discuss more of the risks of the surgery, as well as more of the detail of the possible benefits that will be very pertinent to you. These are the general risks of the surgery. For a summary, surgery for movement disorders is safe and effective. If we look at the last hundreds of patients that we treated, the overwhelming majority did well, had improvements in the motor symptoms, improvements in stiffness, slowness, tremor, freezing of gait, and other motor symptoms. There are, of course, risks always, but the odds are favorable. Cleveland Clinic is a large, specialized, and has a dedicated team for surgery for patients with Parkinson's disease. It is something that we have done for a long time, and we are very dedicated to it. The team is here for you. None of this matters if we cannot individualize our treatment. The experience that we have is directed to you, and patients first is the motto that we live by at Cleveland Clinic. There are several technical options, and the reason that we like to have several technical options is because every patient has specific needs. I want to end by thanking you for the opportunity to talk to you today, and our team is here for you and looking forward to seeing you in the future. Thank you very much.